Thank you so much for coming. I hope that the candy has gotten at least part of the way around. If you didn't get it, well, I'm sure there will be leftover because it seems like I was a little overzealous in buying candy. But as you can all understand, finals are coming up, so I was like, all the candy in my basket. Okay, so thank you so much for coming to APhA, CPhA's legislative talk. We're basically going to give you as many tools as possible for interviews and anything that you might need in order to speak to the legislation that's happening right now. So it could be just talking to a pharmacist that you encounter this information. It could be an interview. It could be many different instances. And it's just important for us to keep on it because especially with SB 493, as you'll find out, it's going to be kind of changing what we can do as pharmacists. So it's pretty exciting and we just need to make sure that we're up on everything. So thank you so much for coming. You guys are great. And thank you so much to Dr. Ferrone for putting this on for us and taking time out of his busy schedule. Thank you.
Yeah.
Slides in the video.
I was just about to say I'm going to send Kari all the PDFs of the slides, and there's some additional information as well that I think you might find useful. So I'll send it to her tonight, and we can send it out on the listserv. So yeah, thanks for showing up during your lunch and everything. I guess being the individual that I am, I'll give you a quick disclosure of. This is not meant to substitute the opinions and thoughts of an attorney. You need to speak to one if you've got any particular legal issues. And this I'm going to talk about, and I guess this is what I want to sort of tease out, is that I'm not going to discuss health policy. I'm talking about legislation. I'm going to talk about legally what's going on, what's changing, what's evolving, what's on the happening at the legislative level, completely separate from health policy. Whether or not you should or shouldn't do something is completely separate. I'm just going to tell you about the legal issues. And again, just like as we had talked about, why should you even care about all of the legal changes and everything? That first of all, remember that we're the most regulated of all the healthcare professions. If you compare us to medicine, dentistry, any nursing, I mean, we have the most laws that regulate us, and they are constantly changing. It's your responsibility to keep up to date on all of them. And in addition, not just for your own professionalism, educating patients, California citizens as a whole. We had a number of propositions and everything that were on the ballot a couple weeks ago that actually were pharmacy related. So you having an understanding of what services just that impact citizens can be important. And again, as I said in class, and what I'll say to you and what I'll tell you at board review when I see you again at fourth year graduation, I'm always going to provide you with the legal references. So if you have any questions or doubt about what I'm saying, you can automatically look it up. I've referenced everything here for you. Constantly people are saying, oh, I see this going on in my pharmacy, or I read this somewhere else. By all means, you're professionals. You have the ability to research and double check things yourselves, and I would encourage you to do that. Okay, so there were a couple things that I gave you that I'll put in your packet in terms of where you can find law and keep up to date on it. But I'll let you look over that yourself. I'll start by telling you the overview of what I'm going to discuss with you over the next 45 minutes. So I divided it out into three different sections. What's going on at the State Board of Pharmacy level. Remember, that's where all the regulations are being made. Talk to you about what's going on at our state level regarding California legislation, things that have passed and things that may be pending. and then talk to you at the federal level of what's going on in terms of pharmacy legislation that incorporates all 50 states. So let's start with the state board. A couple things I want to show you are some recently approved regulations that you may or may not be aware of. First of all, they updated all the fees, so everything's more expensive now. Things that you may be interested in, they amended partial filling of C2s. So if you're working in a skilled nursing facility and have a terminal patient, a patient with a terminal illness, you can now partially fill Schedule II substances. Couldn't be done before. They had updated some definitions on unprofessional conduct and had amended criteria for rehabilitation. The only reason why I point this out is, again, when you apply for your pharmacy licensure, oftentimes if you've had some criminal activity in your past, whether that be DUI or even something simple as shoplifting, it could potentially impact your ability to get licensed. And the unprofessional conduct definitions and the rehabilitation criteria has changed and may impact you in that capacity. Those were things that were recently passed. So there's only two big things that were passed by the state board this year. There are two pending things that are going on right now that have not been passed but have completed their public comment period and have returned back to the state board for further consideration. First of all, the patient-centered labels. As you remember, there are standardized instructions in the state of California with respect to how instructions to take medicines should be printed on the label. Those instructions are being looked at and considered for revision. In addition, you may remember that the only requirement to have a manufacturer on your label is when you have a generic medication. They are discussing the need whether the manufacturer needs to be on the label at all, or if it should be both for generic and for brands. And in some instances, the statement blank generic for blank, if that should be something that is required for all labels. It's currently not, but it's under consideration. So this is being discussed right now at the state board. The second pending regulation that has not passed, but again has gone beyond its public comment period and returned back to the state board for further consideration, involves that with compounded drug preps. You may or may not remember, but this year was the implementation of SB 294. It actually was passed at the same time as SB 493, but 493 overshadowed 294. SB 294 has to do with sterile compounding. This was in result to the NECC debacle up in Boston. Our state board's response to this was that every pharmacy that's dispensing any type of sterile product to any patient in the state of California be licensed as a sterile compounding pharmacy. That was not the case before. And that also includes hospitals. So all hospitals that do any type of sterile compounding had to get an additional license this year, and that went into effect on July 1st. The problem with this implementation of the new sterile compounding license and the ability now of our state board to actually go outside of California and inspect other pharmacies located in other states that do sterile compounding and send products to California was that the legislation, SB 294, was incongruent with respect to certain terminology and already existing regulations. So part of this amendment and this pending regulation is designed to fix some technicalities that we have in our regulations. For example, and one of the reasons why this surfaced, if you work at Kaiser has multiple hospitals throughout California, and got inspected by the state board throughout the year. Kaiser has one set of policies and procedures with how they do sterile compounding, whether or not you're in Northern California or in Southern California. However, when the inspectors went in, each of the hospitals of Kaiser actually got cited for different issues. And Kaiser's response was, well, I don't understand how we could do something standardized amongst all of our hospitals, yet you cite all of us differently depending on who the inspector was. So even the inspectors had different interpretations of the regulations. So our board is trying to fix some of the technical issues and terminology in detail with respect to sterile compounding. Those are the two sort of pending regulations that are on the docket for approval. If you remember, our state board actually has standing committees and then ad hoc committees. And each of the committees is responsible for developing certain pieces of regulation and or modifying existing regulation. And what I wanted to do was sort of highlight for you some of the things that these individual committees are addressing right now. These ad hoc committees, implementation of SB 493 and prescription drug abuse, I'll talk about them as well and how those can impact you. Our Enforcement and Compounding Committee. This is a standing committee by the state board, and it's actually looking at a couple of things right now. First of all, they're reevaluating the need for warning labels on prescription containers. I had you in law memorize a set number of drugs in which auxiliary labels had to be placed. There were certain pharmacological classes, anticholinergics, opioids with CNS effects, so on and so forth, of which you were required by California law to put that it could impact or impair the ability of an individual to drive a vehicle. Also, good professional practice would indicate that you not mix it with alcohol as well. They're discussing the need to actually expand that list of medications and or contract it, because we're finding that the number of medications that fall in here is growing and that the classes are changing as well. So the enforcement committee is determining what they want to do with warning labels. Something else that they're looking at is we're finding that there's a lot of diversion among retail stores regarding controlled substances. Not only diversion, but actual theft and loss as well. Because part of the responsibility of the state board is to minimize drug theft, one of the things that they're considering is developing a new regulation that would require all retail pharmacies to do monthly inventories of their controlled substances and identify their top 10 moving drugs. Now currently, as you remember, the only time that you need to do a controlled substance inventory is biennially. That's done through federal regulation. If your pharmacy does it more often than that, then that's good individual pharmacy policy. The state board is now considering implementing a law that would force the pharmacies to do monthly inventories in order to keep track and also identify their top 10 movers. You may or may not be aware, but in September of this year, the DEA passed a law that actually allows pharmacies to take back prescription medication, in particular controlled substances. You probably, is anyone at a pharmacy right now where that's happening? Okay, so this is the thing. So again, most pharmacies don't want to take meds back. In the past, we have had, instructions for patients to say, this is how to properly dispose of your medicine. Or the DEA had a national take-back day, usually in April and sometime in November. The DEA would set up shop at different police facilities and people could bring in all of their medications there. This year, the DEA said now any DEA registrant, whether that's a wholesaler, manufacturer, or pharmacy, they themselves can take back controlled substances. Well, the problem is very much like you've just shown, most people don't want to take those back. So the state board is trying to determine, based upon consumer advocacy groups that say, yes, yes, we want to take all of our meds back to Safeway. We want to take them all back to Walgreens. But Walgreens is like, well, I don't want them yet. So the board is going to come up with some regulations in terms of how to store the meds, how to segregate them, how they should be secured, should they be single locked, double locked, how you transfer them out, how you take their inventory. So this committee is discussing and considering now how to implement this federal law of allowing pharmacies to take back prescription drugs. So again, legally it can be done. Pharmacies don't know exactly how to do it, which is why they're waiting for advice from the state board before they actually implement it. It's not requiring them to take them back. A pharmacy could say, no, I don't want to participate, but those that do will have some guidance from the state board. The licensing committee, another standing committee of our state board, is actually reviewing your CPhA right now. So there was a job description survey that was released in June of this year that went to all licensed pharmacists. I actually filled one out myself. They take back the survey from all of the practicing pharmacists, and then they'll do an analysis of it, and then they'll redesign the competencies for 2015 to 2020, which will impact all of you. And if you aren't already aware, too, the NAPLEX has already been redesigned, and it will go into effect November of 2015 next year. There's actually a compounding section on the NAPLEX now. The Communication and Public Education Committee of the State Board. So they are actually looking at our laws for patient consultation. We all know that when a patient gets a new medication, that they're required by law to get counseled on it. And the law even tells you exactly what you should be counseling your patient on. One thing that you should be counseling your patient on is where to store the medicine. How many people actually counsel the patient on where to store their medicine? Yeah, that's what the state board is finding as well. That, and it's not just, keep this in the refrigerator or keep this at room temperature. It's, you really shouldn't keep this in your bathroom where the humidity is high. You should be keeping it in these types of cabinets or these areas of your home. By law, you're supposed to be telling people that, and most do not. So the state board is now considering what is actually needed for patient consultation and when patient consultation needs to occur. We're also finding, too, that just like you've alluded to, most pharmacists are not counseling their patients. And they don't know exactly why. Some of the data shows it's time. Retail is a business. You're required to push out so many drugs. You don't really necessarily have time or the personnel to spend with an individual patient and counsel them. It can also be training. What we're finding out too is that most pharmacists are shy and don't want to counsel or engage their patients, not only from an educational standpoint, but just from a personal and social interaction in terms of training. And the discussion now is should there be routine training, routine continuing education in order to counsel patients? I actually took a group of students, it was a group of third years, last year with me to pick up one of my medications and requested the pharmacist to counsel, and we all watched. And all the pharmacist said was, Mr. Ferrone, this is a good drug. It's a really good drug. It'll work. You should take it once a day, and this is a good drug. Do you have any questions? And that was how he counseled me on doxycycline antibiotic. So again, it's time, it's training. Again, most of the pharmacists just simply read off of the pamphlet. So our board is re-examining the requirement of patient consultation. Not that they're going to eliminate it, but they're going to evaluate why it's not happening, update potentially what needs to be included in a counseling session, and provide individuals with additional training that if you're not doing it on a routine basis, you'll feel more comfortable with it. The next thing that our education committee, communication and education committee is looking at, and this had hit the news a couple months ago, is the translation of prescription labels. You know, right now, there's a requirement in California law that if you have a patient that is of limited English proficiency, or English as a second language, that you can in fact, and need to by law, find an interpreter for that individual. In fact, the state board provides a multilingual sheet of paper which the patient would point to their individual language, and then the pharmacist can find an interpreter in order to communicate with the patient. The law, however, does not require that you provide to them a prescription label with their language of choice. This has caused a lot of debate within California because most pharmacists do not want to dispense a medication that contains a label with a language that they don't know or understand because of the liability issues associated with it. The model, however, is New York. New York has passed a law called SafeRx that actually requires retail pharmacies in the state of New York to actually be able to translate their prescription labels into 5 different languages. English and 4 additional languages like Russian, Italian, Chinese, and that's all based upon the population makeup of the state. Now, what people don't realize and what has sort of spun out of control in our media is, again, A, the liability associated with the pharmacist, and B, would this actually help the patient? In New York, and this is where people have not read the law, in New York, it does not require all retail pharmacies to do this. It only requires retail pharmacies that have 8 or more pharmacies within a common ownership. So it's the major chains that have 8 or more pharmacies that are required to do this. They have the money and the financial resources and the software capability to do this, and or contract out to a third party in order to get that done. And the New York law clearly states that the pharmacist won't be liable for any translation errors. So there's actually a number of pieces of caveats that can be added to our regulation in order to prevent pharmacist liability and still be able to meet the needs of a lot of our patients. All right, so let me talk to you about what's going on with SB 493. So just as a recap, SB 493 essentially provides us with provider status in the state of California, and it adds 2 additional levels of service. There's additional activities that all pharmacists will be able to provide in the state of California. And then it creates a new licensure subcategory, an advanced pharmacy practitioner, to provide additional duties. The thing that you should know is that even though the law's been passed, it is still now undergoing development and implementation within the state board. Remember that this is a state-level piece of legislation. It was passed by our state legislation. It is now the responsibility of the administrative agency, the California State Board, to actually interpret that statutory law and put into regulations something that day-to-day professionals, pharmacists, interns such as yourself can follow. So there's a couple of things that I wanted to share with you just to update you in terms of what's been going on. As I pointed out, the state board created an SB 493 implementation committee, and it meets fairly regularly. if you have not gone to, has anyone gone to the committee meetings? I would actually, if you had the opportunity, go to the board website, get the schedule, and you should go up to Sacramento and participate. There are actually students from all the other schools that are there, and you can see them. It's all recorded in the record, and you can see them participating and giving their thoughts. And it would be nice. Lisa Kroon and Robin Corelli are there regularly. It would be nice to also have some students there if you're interested as well. SB 493 essentially has the following components for us as pharmacists. It allows us to provide nicotine replacement products for patients. And traditionally, that would include any sort of nicotine replacement, such as the patches, but that also includes the inhaler as well. It does not include Chantix or Zyban. Those are not considered nicotine replacement. The protocol for the nicotine replacement products is being developed right now. They're actually modeling it after the entire program that we're doing here at UCSF. The discussion, though, that actually is occurring right now and has not been settled is the need for certification. Do you need to be certified in order to furnish to your patients nicotine replacement products? Or is simply graduating from a school like UCSF enough? Or, what's the time frame of graduation? Could someone like myself that graduated in 2003 provide these products, or do I need certification? And where does the certification come from? Currently, the program that's done by Lisa Kroon and Robin Corelli does not have a formal certification associated with it. It is something that they're actually considering right now implementing in order to maintain congruency with the regulation. Same sort of thing with the self-administered hormonal contraception. In general, that's going to include anything that's given orally, that's provided topically like a patch, and it can also include the vaginal ring. The protocol, which is being done in conjunction with the medical board, is still being developed right now, as well as the appropriate education and training that's decided for the individual. They have implemented parameters for the APhA licensure. You either have to be board certified, and there's a number of board certifications, complete residency training, or have a particular amount of clinical experience in a particular situation. And you have to meet 2 of those 3. There are still some discussions about this. They have drafted the actual application. It's something that you will have to apply for and that the state board will have to approve. And it is something that they will track and monitor just like they track and monitor your normal pharmacy license. Immunizations and travel medications. The whole concept of travel medicine is actually fairly broad, and that's what the committee is discussing right now. We traditionally think of immunizations for travel, malaria, yellow fever, things like that. But there are a number of other components of health medicine outside of immunizations. Traveler's diarrhea, jet lag, things like that. And our ability to provide those medications are actually existing now. They are putting together a protocol and a list of medications of which they have not yet approved, but is also, again, under discussion because travel medications, and one of the things that they discussed at the most recent board meeting is what happens when there's an outbreak. Clinical practice could change, could be updated, and if you're bound by a particular protocol, you won't be able to make those professional decisions based upon that outbreak. So the discussion right now is how broad or how specific to make that individual protocol. Same thing with ordering tests. Traditionally, pharmacists as a whole will be able to order any sort of drug-related therapy test. The difference between the APP and the general pharmacist will be that the APP now has the authority to actually go ahead and modify drug therapy based upon those lab levels, whereas the pharmacist without the APP designation will have to get physician permission. Now you, as an APP, doing any sort of medication modification, including giving patients immunizations or travel medicines, part of SB 493 requires that you report back to the physician and or the common medical record. The deadline in which you have to do that is still being discussed at the state board level. Anything from, immediately, 24 hours, 7 days, all of that's still being discussed and hasn't been fleshed out yet. One of the things that I'll attach to the end of these lecture notes is the timeline template. They have, the state board, identified the timeline between now and July of 2015 of which they plan to reconcile and solve all of these issues. And then I've also got sample protocols in terms of the nicotine replacement, the hormones, the travel health, of what they're looking at right now. It's not the final protocol and it's not the final scope of your practice, but it'll give you an idea of what you'll be able to do in the next coming months. Any questions on the state board? All right, so let's take a look at what's going on at the state legislature level. So at the state level, we had a couple of things passed. Senate Bill 1093, which had to do with hospital pharmacy. Traditionally, and if you work in a hospital, you know that part of your role is to prepare emergency drug carts and fill automated dispensing machines throughout the hospital. Each of the nursing floors has their own set of medications. Historically, it could be filled by techs, but it needed still to be checked by pharmacists. This actually expands technician ability. It permits the tech to actually fill and seal the emergency drug trays and containers that go out. And it also allows technicians to actually inspect drugs that are maintained in the hospital. Because again, you already know that on a monthly basis, at a minimum, you've got to go around and check expiration dates and do inspections of nursing stations. Whether or not hospitals choose to engage technicians in this is another story, but it does allow the capacity for the technicians to do this. Hypodermic needles. I want to talk to you about what our current law states, which actually expires at the end of this year, and then I'll tell you what the new law will do. So our current law, what I taught you in law class, is that you can in fact sell hypodermic needles to patients without a prescription under certain circumstances. They've already had a prescription, the patient's known to the pharmacist, and they have a medical need for it. Or if they simply just want to shoot up and it's for personal use, you can sell it to them for 30, no more than 30 at a time. I mean, this is health policy, public health, this is what it's for. The idea is that we can prevent transmission of certain diseases by allowing and giving individuals fresh and new syringes versus sharing needles. So this is more of a public health policy in terms of why we do this. We know that there's going to be individuals that are doing drugs. We might as well provide them with some safety aspects. If pharmacies choose to sell individuals needles without prescriptions, then part of the counseling has to include accessing drug treatment, proper ways of disposal, and identifying areas in which they can get tested for HIV and Hep C. And then the pharmacies also have to be able to provide some sort of on-site collection for the used needles, mail-back containers, or personal sharps containers. This law expires December 31st of this year. There was actually a new law that's already on the books, 4145, that allowed pharmacies to continue to dispense needles, but they had to be associated with certain Department of Public Health programs. That law has now been removed. There was a new piece of legislation that was passed this year, AB 1743, that removes the sunset date, in other words, the expiration date of the current law, and removes the 30 needle limit. So now, starting January 1st, they can buy as many as they want. They still have to go through the same sort of access situation of providing the patient with ways to access drug treatment, safe way of disposal, and identifying where they can get tested. But the limits for the needle has been removed, and that becomes effective January 1st. Furnishing naloxone products. I don't know if you were aware, but APhA was approved this year. This is a self-administration of Narcan used for opioid overdose, very much like your EpiPen. The difference between this and the EpiPen is there's actually a speaker, and it talks you through the entire self-administration process. It's kind of like an AED. Has anyone used it? No, you should check the video. Well, you should. I would not used it. Let me say, have you used the trainer device? If you've not seen it, APhA comes as a pack of 2. It's 0.4 milligrams per 0.4 mLs. 2 individual self-administrative syringes and a trainer. So there's a box of 3. 2 of them are active. One's a placebo for a trainer. The idea is that anyone that's abusing drugs or anyone that's on high-dose opioid therapy, pain medicine, should be always carrying around with them at least 2 APhA syringes. Part of the APhA manufacturing process and part of the legislation, not only here in California, but actually throughout the United States, was to actually give APhA to key individuals in the field. So police, EMTs, now pharmacists. So AB 1535 allows a pharmacist to furnish a Narcan product according to state protocol. Much like SB 493, the state protocol has not been defined yet. It will be similar to the emergency contraception, similar to the 493, in which the state board and the medical board work together and come up with a Narcan protocol. And just like the other protocols, the pharmacist will actually have to complete at least 1 hour of continuing education credit regarding opioid antagonist products. What we have found is that, at least in the other states that have already implemented these types of laws, the most people that are using this are those in the field, so police officers, and they're reviving mainly heroin addicts, which they are getting revived, but then they're finding out that we're not doing anything to address the addiction. And so the police officers are seeing the same people that they treated with APhA like every week. So part of the thing, and this may be of interest to you in terms of health policy, is that as pharmacists become able and have the capacity to furnish APhA, that we should look not only at just getting access to APhA for those patients in need, but also once we treat them with APhA, what are we going to do about their addiction? Otherwise, we're just going to be constantly sending the APhA out. Let me give you a status on your intern hour update. So, as you know, right now, state law, Business and Professional Code, says that you need 1,500 hours in order to sit for your exam and get licensed. The California board says that 600 of them can come from school, 900 of them have to come on your own through pharmacy work. Interestingly enough, if you look at ACPE accreditation, and you are part of an ACPE accredited school, the number of hours of IPPEs and APPEs add up to 1740. 1740 is well above your 1500 minimum. So the question becomes, why do we even need to have the intern hours? Because we get way more than that by simply graduating from school. So a number of us throughout the state, UCSF actually paired up with UC San Diego, and there were a number of students actually that were part of this group, including myself, actually advocated for the state board to change this. It requires not only a regulatory change, but a statutory change. Again, because it's part of the professional code, our legislation has to amend it. We were able to convince the state board that simply graduating from an accredited school with the 1740 hours would be significant, and that you didn't need to earn extra 900 on your own. Now, did anybody go to CSHP? Did you go to the House of Delegates? No. Okay, so the reason why I point this out is the group from UCSF and UC San Diego, in addition to all the other schools, advocated for the state board to remove the 1500 hours, and the board voted to do that. Then, in November, here in San Francisco, at CSHP, the House of Delegates said, you know what, we don't support this. We actually want them to get the extra 900 hours. So during CSHP here in San Francisco, little did you know, there was a huge fight that was brewing amongst all the schools, the House of Delegates, individuals at CSHP, as to whether or not this should be removed. Now, in reality, let me give you sort of a reality check. The House of Delegates has no power. They've got no legal authority. They can't do anything. However, they can influence policy. So they could easily go to our state legislature and go, hey, we're lobbyists, we're paying you a lot of money. We don't want you to vote for this amendment. We need the 1500 hours to stay the same. Okay, so the interesting thing, part of that House of Delegates is that the individuals in the House of Delegates that actually opposed this actually supported it back in March, and we had them on record saying, yeah, we actually support this. So we went back to them in San Francisco during CSHP and showed them transcripts and said, well, what changed over the past couple of months? Because back in March you said this was okay, and they kind of scratched their head and they went, oh yeah. So now CSHP supports this. The state board actually is preparing for statutory and regulatory change. It will appear in the omnibus bill, which is just a bill dump of a number of things for 2015. It has not been formally written, and it has not been formally placed in the omnibus bill yet, but that's the plan for it. So unfortunately, I don't think it will impact you, but I'm letting you know that it's on the way. All right, let me give you two quick federal issues and then we'll wrap up. So, Drug Quality and Security Act, this was actually signed by President Obama last year. The issue that's important about this is Title I, the Compounding Quality Act. This actually created a registration at the federal level for a compounding pharmacy to be identified as an outsourcing facility, or what we call a 503B. These are sort of some talking points and everything that you may hear about what's going on. The FDA has the authority to regulate any pharmacy because of interstate commerce under 503A. So if the FDA all of a sudden knocks on your door, the authority they have is from the the FDA and the Food, Drug, and Cosmetic Act 503A. 503B is new, and it creates an outsourcing facility that follows GMP compliance, allows the pharmacy to be inspected by the FDA, and has additional reporting requirements for the FDA. The reason why this is important is hospitals that need to outsource or purchase special compounded medicines, even other compounding facilities that need to get special medicines can choose now to go to a 503B registered facility. In November of this year, registration guidance was updated by the FDA and fees were updated by the FDA. Over the past year, once the legislation went into effect, any pharmacy that applied for registration could do it for free. Now they have to pay. The thing that I want to point out to you is that California still has a requirement that they be registered as a sterile compounding facility in California. Just because you have this federal registration does not mean that you can send drugs all over the United States. You still have to comply with state law. Last thing I'll point out to you from a federal standpoint, HR 4190, which is taking a look at provider status at a federal level. The bill was actually introduced into the House this year in March. The first thing that happens anytime a bill is introduced is it goes into committee. It went to the Ways and Means Committee, which actually deals with revenue, so any type of financial issue or revenue issue automatically goes to Ways and Means. Energy and Commerce has to deal with health. They have a subcommittee on health. So because it's had to do with pharmacist practice and identifying them as providers, that went to the House and Energy Commerce Committee. And it has to do with revenue because this bill also allowed for reimbursement. It is a bipartisan bill that actually amends part of the Social Security Act that allows for Medicare coverage of pharmacist services on a federal level throughout the United States for medically underserved populations. And it specifies the amount of reimbursement that can actually be obtained by the pharmacist. The issue now is that it is still stuck in committee, and chances are it will die in committee, so this probably won't go anywhere. It's just brewing in these two committees right now and hasn't moved out anywhere because of other pressing issues, and will likely die. The end of the congressional term is this year, but they still have some time to reevaluate it. That's all the time I have. Thank you for coming. Kari will send out all the notes. If you got questions, let me know.
So thank you everybody for coming. I will send everything out. Does anyone know where the candy went? Okay, so make sure you guys